So, hello and welcome. We have a very exciting panel of experts that we're speaking with today on the lead. And this is actually a chance panel that was born out of the discovery that in two very different parts of the world, the US and in India, in Tamil Nadu, in fact, we have had doctors formulating very similar treatment protocols for COVID patients. And both these teams, without communicating with each other, have individually settled on a steroid called methylprednisolone as a key drug in keeping patients out of the ICU. And this is the reason we are going to talk about collaboration today and why it is so important to share knowledge globally. So let me introduce our experts first. We have a team of doctors from the US. They are with the FLCCC Alliance, which is the Frontline COVID-19 Critical Care Alliance. And this is a team that has formulated what is called the MATH plus treatment protocol. And we'll, of course, explain that later. The doctors themselves will explain that later. We have Dr. G. Umberto Meduri. He's the professor of medicine, division of pulmonary critical care and sleep medicine at the University of Tennessee Health Science Center. Dr. Pierre Corey, medical director, trauma and life support center and critical care service chief. He's also an assistant professor of medicine at the University of Wisconsin's School of Medicine and Public Health. Dr. Scott Mitchell, associate specialist with the emergency department at the Princess Elizabeth Hospital in the states of Guernsey. And joining us from Delhi is Dr. Giridhar, who is with India's premier All India Institute of Medical Science, or AIMS, and Dr. Parandhaman, who is a professor of medicine at the Kilpauk Medical College and Hospital in Chennai. He is also part of the COVID expert panel put together by the state government of Tamil Nadu. And he is the person who has formulated the LAMP and PALM protocols that are yielding tremendous results for the state so far. So before we get into the discussion, let's first understand from these doctors what these two protocols mean and what they have in common. So may I request Dr. Meduri to please explain what the MAT plus protocol actually means.
So MEF plus, M is for methylprednisolone, A is for ascorbic acid or vitamin C, T is for thiamine, and H is for heparin. So what we have in common with your protocol is methylprednisolone and anticoagulation. What is missing is ascorbic acid and thiamine, and also vitamin D and other things that we call as complementary or treatment to go with this. The reason for adding those two very important vitamins is that the steroids that we give as the anti-inflammatory methylprednisolone works on a receptor called glucocorticoid receptor. And the health of that receptor, the function of that receptor is dependent upon adequate vitamin levels. So when we supplement with vitamins, we make the receptor work better and allow steroids to be much more powerful. So the combination works better than giving methylprednisolone alone. And in critical illness, this level of vitamins rapidly decrease within a few hours. So in essence, there is a strong deficiency. The deficiency correlates with outcome. So it is very important to supplement vitamins in critically ill patients. So methylprednisolone is now is a corticosteroid. Following the recovery trial, now the corticosteroids is not a bad word anymore in the treatment of viral pneumonia like COVID-19. So this is very important. So now there is an acceptance that there is a role for corticosteroids. What I'm happy that your group has done is disregarding the WHO guidelines. The WHO guidelines, I'm not sure who wrote the part related to steroids, but either was inebriated or was a completely incompetent human being. What he had for sure is laziness. He did not review the literature. And so I've worked on this for 30 years. So I carefully reviewed the literature and wrote a paper together with other investigators from Europe and United States against the WHO guidelines. Let me make a summary. the inflammation that we see in COVID-19 is qualitatively similar to the one that we see in acute respiratory distress syndrome. So all these cytokines that goes up, all this clotting that we see, all the fibroproliferation going to fibrosis is shared with that, is a stereotypical response. In other words, the body reacts that way to a host of insults, nothing different. So what do we know about ARDS is that steroids work. There was a question regarding the use of steroids until February of this year, when the Spanish group of Villar published in Lancet the confirmatory trial in patients require a safe mode of ventilation. So the steroids work for ARDS, the chapter is closed. So we have a disease that has a lot of similarity to ARDS, that has both histological and radiographic findings like the ground glass appearance that to a pulmonologist say it needs steroids. So theoretically should respond to steroids. So what the WHO did is state that it did not work in SARS, it did not work in H1N1, it did not work on MERS. And they quoted meta-analysis from 2006, incomplete meta-analysis. And you know, meta-analysis now is becoming an industry. People just put all this data together and then they get results. So unless you know how to put the data in, the results are worthless. But what they did not included in the WHO report are large-scale data sets from China. In SARS, 5,200, 300 patients, H1N1, 2,200 patients. And what those large data set did is, number one, they make adjustment for condition that can cause confusion, the confounder. So they adjusted for that. And then they looked at specific treatment. What treatment worked? Because the corticosteroids, we have a lot. Okay, dosage, duration, timing, etc. And what they found is that of methylprednisolone 80 milligrams for a duration of weeks is the one associated with the best improvement in outcome. They found a 70% reduction in thousands of patients that were studied with SARS, and another 50% reduction in patients with H1N1. So they've not reported the data from this study. They report data from a smaller study. Then to make this even more convincing, not using steroids, they look at the complications and they report data from 2 Chinese studies regarding complication. One is that you develop diabetes. They didn't even say hypoglycemia. They said diabetes makes no sense. The other one that report osteonecrosis. When you look at those 2 papers that apparently did not do, well, the paper said that when you use the average dose of steroids, there is no complication. Only when you use massive doses of steroids, there are complications. And the reason why they use steroids in the paper they talk about osteonecrosis was not for SARS, was not for the pneumonia, was for stroke. Somehow they have these high doses for stroke. I'm not sure why, but was very clear when there was dose dependent. And then frequently, you have seen that, they report a study on MERS from Dr. Arabi in Saudi Arabia, beautiful study. The problem is nobody reads it. Okay, so the study said that there is a reduction in viral clearance. So that's a broad response. Then when you look at the data reported in a table 4, what does it show? That if you use steroids for greater than 7 days, so pay attention to this, if you use steroids for greater than 7 days in MERS, there is no impact on viral clearance, none. And there is a 50% reduction in mortality. So somehow all this data were not seen, and the WHO make a categorical statement not to use it. In other words, what they say is, based on incomplete and faulty review of the literature, not to use an anti-inflammatory treatment that we always use for lung inflammation in people that die from massive inflammation. I think that was a huge, huge mistake that the WHO. And now we have with the recovery trial the confirmation. It's not just the recovery trial. There's a study from Italy on methylprednisolone, 80 milligrams a day and then titrate it down after 8 days based on the reduction in C-reactive proteins, that shows a 70% reduction in mortality. There are studies from Spain, studies from France, so, and of course, some from China. They also show a reduction in a large study from the United States, Henry Ford Hospital, that when you use it early, okay, there is also an improvement in all these parameters. So the literature is coming out little by little, but the best study is the one from the recovery. 2,000 patients receive steroids. We've never seen anything like this. So pretty much the taboo placed on using steroids is gone. So now the question is how to do it. Well, I agree with your approach, methylprednisolone. Why? Methylprednisolone is a fantastic drug. Number one, it is a drug that has a very good binding to the receptor. And once you bind to the receptor, then you have the action. Because it's synthetic, it's not degraded by the body. In other words, there is no problem going inside the cells and do the work. Number two, it is the best drug for penetration in the lung. Okay, so penetrates into the lung, and the lung levels, the level in the tissue of the lung, are superior to the one in the blood. Okay, so very, very important. Now, how to give methylprednisolone? So we are submitting now to Lancet pharmacodynamic and pharmacokinetic study looking at dexamethasone, hydrocortisone, and methylprednisolone in ARDS. So I'm gonna summarize you the best way to give a drug. Number one, you need 80 milligram or even 100 to saturate the receptor. If you want immediate action, you need to saturate the receptor. But then if you want to keep the action going on, it's better to give it as an infusion, not as bolus Q6 hours. When you give a bolus Q6 hours, you have mountains and valley, mountains and valley. So when the level is down to the valley, there is no effect. Okay, so if you do an infusion, you keep at the mountain peak all the time. And you guys from India know about the mountains. So you keep at that level so that what we call are resistant to steroids, like smokers, obese patients, sometimes also diabetics. So when you start steroids, you need to monitor the C-reactive protein level. And if a C-reactive protein level doesn't come down, if your oxygenation does not improve in 72 hours, okay, then if a patient deteriorates, you can double. You can go from 80 to 160. That's safe. That is absolutely safe. What we know from the Italian study that is submitted for publication, is available on Medrix, is that the viral clearance is not impacted by methylprednisolone. It is safe. The rate of complication are identical to the control group. So except for hyperglycemia at the beginning with the bolus. But hyperglycemia at the beginning is very good because that sugar is essential for the mitochondria to generate the energy that you need to support all the host response in critical illness. So it's not a bad stuff. And when you do an infusion, then the hyperglycemia comes down. There is no spike related to bolus. So that's my recommendation.
Great. Now, you've spoken about the MADH plus protocol, and I believe that the LAMP protocol developed by Dr. Parandaman and his team are pretty similar. So, Dr. Parandaman, very briefly, could you tell us what the LAMP protocol is actually about, and how did you stumble upon methylprednisolone as a drug that would really help keep patients outside the ICU?
How we started, because the patient we don't have any protocol before. It's a new disease, and we had to read about the disease. What is the virus? How the presentation, and what are the pathophysiology. So when we read this pathophysiology of the virus and the virus action, we found that primarily the pulmonary vascular thrombosis is the one which causing the inflammation. So, what the two, and as at particular point of time, there is no effective antiviral at that point of time because there is no effective and safer antiviral which can address the virus clearance. So the only thing is option is dealing with the pathology. So we try to block the pathology or target the pathology, what's happening in the lungs. So there are two things we found. we found one, there is a thrombosis because it's a hypercarbonated state, because the virus, the endothelium, ACE2 receptors are more in the pulmonary vasculature and endothelium. The virus involvement is more there. So as far as this the data is concerned, more than 90% or 80 to 90% of the ACE receptors in the pulmonary vasculature. So the involvement of the pulmonary vasculature is more. The endothelial damage is more. As a result of endothelial damage, the inflammation is more. The inflammation is a non-infectious inflammation. So there are two things there. One, there is inflammation. Two, there is a coagulation. So these three things, two things, if you address, probably we can improve the outcome. So you can improve. That's what how we started. So we started giving low molecular heparin because that's the one which is causing the problem. And two, following the this obstruction, there is inflammation, that is death, cell death and inflammation. So we started which drug is a ideal drug. As Mitchell, as a writer pointed rightly, the drug, the steroid which penetrates into the lung and endothelium or epithelium and the pulmonary parenchyma is better with the methylprednisolone than dexamethasone. When you see the dexamethasone, if you see the literature, the penetration to the brain is more. And any meningeal problem, we use a dexamethasone because the penetration to the meninges and to the concentration of the brain is more. So when you want to use a drug which is the lungs, that you choose a drug which is penetration to the lung is more than the other areas. That's how we give priority to methylprednisolone. So big and moreover it's very effective. So any critical care management, they use methylprednisolone for the lung involvement because acute lung injury, bronchial asthma, and COPD, and because its concentration is more. So based on this consensus, we started preferring methylprednisolone because this is inflammation. So that's the one thing. And third thing is because, and I mean sometimes it's not infection is those not very common in this COVID lung involvement. That's because secondary infection may be there. We are actually we do not know how it's occurring. Maybe whenever there is pneumonia, maybe communicable pneumonia also. For a communicable pneumonia, the primary drug will be the macrolide, and followed if at all it's a severe infection, we add this gram negative coverage or gram positive coverage like ceftriaxone gram positive coverage. So that is a combination. Here we used azithromycin because one for the prevention of there is a there is a, the atypical organism or in secondary infection. Second is immunomodulatory. So 500 milligram stat followed by 250 milligram body is an immunomodulatory dose of azithromycin. So generally we use an antibiotic for any secondary infection in the respiratory tract. So we added that one. Then fourth thing we understood was that here this particular pathology in the lungs, what's the improvement with the prone ventilation, because it's occurring in the peripheries. It's not common with the other ERDS. Other ERDS is diffusely everywhere, even central, lateral, and all the same. But this particular disease involves primarily the peripheries, and where and lower lobe is involved, peripheral zones are involved. And if you put the patient in a prone positioning, and probably the ventilation improves and oxygenation improves, thereby the saturation improves. So we thought the only four things which is a primary, because we do not have any effective antiviral drug. So probably we target the pathology, and we formed is a LAMP, low molecular heparin, azithromycin, and methylprednisolone, and of course prone positioning. That's how we initially we started. As I already mentioned, and after the patient's improvement, there are most of the time patient improves, and patient, if some people are deteriorating in spite of our treatment, so we find out what is the cause of the problem. So in that we found the obese individuals and those who are bronchial asthmatics and diabetic individuals and the hypertension individuals of long-term duration, they are not improving. In those situations, we analyze why these people are not improving, because we are giving the dose as to the 1.5 to 1 milligram per kg methylprednisolone, dexamethasone 40 milligram body my initial stage, and later we do BID dose, and the of course prone pushing putting for everybody. You're non-diabetic and diabetic, and everybody we are putting the same. Why these people are not improving? That we started analyzing. Then later we found that, and there is a receptor in the heart also, and probably the myocarditis, that is COVID myocarditis, maybe in addition to the COVID pneumonia, the primarily 90% of the case, maybe 5 to 10% of the case, the myocarditis following this the infection may trigger possible LV dysfunction that is causing worsening. So the complication by the lung as well as with the heart in a COVID negative patient. So then we started using the small, because clinically we found there are some people, they found that they are orthopenic, they are not able to lie down, they're able to only sitting posture. And those individuals, we started giving small dose of Lasix, that is furosemide, is a 10 to 20 milligram, that is improvement in the saturation from 90 to 95. So if we found we are happy, we again is just challenge the dose. And similarly, we found that those individuals with the comorbids, especially long-term diabetics, hypertension, CAD, even though there is no ECG changes, because the improvement with the furosemide was there, we started using small dose. Then later we analyzed the literature that because of long-term diabetic, there is involvement of the heart, one by the cytokines, and two, the cytokines itself can suppress the heart function, decrease the heart contractility, or COVID myocarditis by the viral receptor after that. Third, because of the stress, any infection can stress precipitate in elderly, and they are not able to tolerate so much of cytokines and stress related, the stress hormones like catecholamines, all these things, probably all together may contribute for worsening of hypoxia in these individuals. So whenever we find the patients with the comorbids, we clinically assess if that's not improving, probably we use small dose of that is furosemide or diuretic. Then we found that there is a lot of improvement. So we are happy. We are adding Lasix. Probably you have to change protocol from pump to maybe adding Lasix, one more Lasix also like that. That's all, because the new disease is nowhere described anywhere because of Lasix and all, because aggravation. It's only the observation. We could not do any study because right now we have 1,700 patients in our hospital, and the inpatient was 45, and the COVID care center we have just 1,250. So there is manpower is less for us. We are not able to do any data analysis. That is the problem with us now. Yes, yes.
If I may ask Dr. Corey, the Oxford recovery trials have promoted dexamethasone as almost a wonder drug in a sense. But what the methylprednisolone appears to be a lot more effective in COVID than dexamethasone. So, and I've read some of the reports that that the FLCCC has provided in terms of mechanical ventilation-free days for methylprednisolone is 8.5 days versus 4.8 days for dexamethasone. There's hospital mortality risk reduction of 49% for methylprednisolone versus 34% for Dexa. So, can you explain the various benefits of using methylprednisolone over dexamethasone, which is recommended by Oxford?
Sure. So maybe a couple of things before I just sort of want to because I appreciated listening to my colleagues, and I just want to summarize a little and emphasize some of the key points that they said, especially for the layperson. So, Dr. Meduri, who's, he said he spent 30 years studying steroids and critical illness. I mean, he is the world's expert, and his contribution in writing the paper showing how the major healthcare societies in the world got this wrong by recommending against steroids. His paper and his insights were just hugely invaluable. He's taught me as a colleague a lot about steroids that I didn't know. And I just have to emphasize that, going into this COVID pandemic, as part of my hospital, when I reviewed the literature and looked at all the studies from SARS and MERS and H1N1, it really does. There's so many trials that show that steroids are harmful. The problem is almost every single one of those trials is very poorly conducted in the sense that it's uncontrolled, and it doesn't control for the severity of illness. Yes, people who died more often got steroids, but it doesn't mean that steroids were harmful. And so it was a really, I think it was a tragic flaw that the studies that were published were not carefully analyzed in the way that an expert like Dr. Meduri and other colleagues did. And so I just want to reemphasize that is that, the world got it wrong. And I think there was a lot of harm that unfortunately was perpetrated by that error. It was a tragic error as we went into this pandemic. But here we go, like you just mentioned, we have the recovery trial, which fortunately, and I give them a lot of credit for conducting a large trial very early on in the pandemic. They got a lot of patients, and they did do a steroid protocol. But here's my take on that, is that what they did in recovery is they used 6 milligrams of dexamethasone a day, which is a few things I want to say about that. Number one, that is not a large dose. If you consider it in terms of a dose of methylprednisolone, it's about 32 milligrams of methylprednisolone. If you heard Dr. Meduri say, when you look at all of the data from all of the thousands of patients who were treated in the prior pandemics, the best dose is 80 milligrams of methylprednisolone. So in the recovery trial, they used the equivalent of 32 milligrams. So they used a lower dose. They also used a different drug than methylprednisolone, which my colleague also mentioned. Dexamethasone has much better penetration to the brain, but the concentrations in the lung, methylprednisolone is much superior. It reaches very high concentrations in the lung. So if you're dealing with a pandemic of a lung injury or a lung problem, methylprednisolone on its face would seem to be the superior drug, not only from prior data, but just from the physiology. And so, so what my take on the recovery trial is, I believe that the results that were reported in the recovery trial are the minimum of what corticosteroid therapy is capable of in this disease. If you have an expert like my esteemed colleagues on this panel, managing the steroid doses and titrating to effect. So for instance, my concern with the recovery trial is if the world blindly follows that trial, which is 6 milligrams a day for, I think the median duration might have been 6 days. I think they were intended to do 10 days, but the median was 6 days, which is a very short duration of a very short dose. Yet they still reported significant benefits. My gosh, if me or any of my colleagues on this panel were managing those patients, a few things would happen. Number one, we would start with a higher dose that has been proven to be more effective. Number two, in my experience treating these COVID patients, I've come across many who were so sick and so hyperinflamed that even 80 milligrams was insufficient. And in a number of cases of me and my circle of colleagues, we've had to double and triple the dose and even employ sort of pulse dose steroids. And we have gotten patients to really respond to higher doses. I'm not saying that higher doses are always necessary. In fact, one of the lessons from the recovery trial, which I think they did beautifully, is they started early. And that's really where I think their benefits from. I don't think their dosing was correct, but their timing was excellent, which is they started early on in the hospital. And I think that's why they had so if you start early, you could probably get away with lower doses, maybe. But when I was in New York, I spent 5 weeks running an ICU in New York. And unfortunately, I was seeing patients with presenting late stage disease in which you really had to sometimes get creative and aggressive with the dosing that you needed. And so those are my thoughts on the recovery trial. I think the world should be grateful for that trial. I think it finally sent a signal. Dr. Meduri also recounted, he can spit out, 3 or 4 of the trials. We're all watching the data. There are numbers of trials coming from multiple different countries. They're not as large and randomized as recovery, but they're showing the same signals: steroids earlier, and especially with methylprednisolone, you're seeing larger benefits. And so I like recovery is great, but I got to tell you, I'm already hearing from colleagues around the world, what are people using in hospitals? Dexamethasone, 6 milligrams a day. I don't want to say that's bad. I think there's something better, and that's where I'll stop.
I'm going across to Dr. Scott Mitchell, and I'm going to ask you probably a question that you may not really like to answer, but I'm going to ask it anyway. How do you see the role of big pharma playing out in all of this? I mean, the fact that the MAT plus protocol, I mean, you guys have been going on about it. You're, beating drums everywhere, and the Tamil Nadu government is, doing all sorts of things, with flooded with patients. Everyone's obviously in different parts of the world, you're finding that a particular set of things works. It is not a cure for the virus. We're not going to find a cure anytime soon. But this is about managing the disease. And all of you have found that certain things work, but this is not out in the mainstream. Why? What is the role of big pharma in this, Dr. Mitchell?
Okay, so just to correct one thing, I'm not actually based in the US. I'm actually from the UK. So I work in Guernsey, which is a small island just between UK and France. So just to correct that. So kind of my own story was going back probably to early mid-March, looking at how this virus pandemic was causing a lot of death, morbidity, etc. in China, and then subsequently in Italy. I think we didn't get a lot of information out of China as to exactly what was going on and what therapy were being given, but they actually had a document called the Shanghai Management Guideline, which, although it contains a lot of other things that probably don't work now, they were using methylprednisolone, ascorbic acid, vitamin C, and anticoagulants as well. So the problem is looking at the situation in Italy. They were just ventilating patients, really just giving supportive therapy early on, and the mortality rate and the utilization of ICU beds was just horrendous. So I thought, really, there must be something more we can think about doing. So kind of serendipitous, I got in touch with Dr. Marek, who I'd come across his work on sepsis. For some reason, I kind of saw a similarity between this disease and sepsis in terms of the sort of hyperinflammation it causes, and that we have to calm that down. So just emailed him sort of mid-March, thinking my original question was actually, because it was early on and we're getting information from the WHO saying steroids shouldn't be used. My question to him as part of his therapy, should we be using steroids in this? At that point, it was still a bit unsure, but he got back to me with his whole, he had a whole strategy for going to treat this disease, which was based upon his originally hydrocortisone, ascorbic acid, and thiamine therapy for sepsis, which in his own studies and elsewhere has shown a huge reduction in mortality for sepsis. So I thought, this treatment is safe. It's not going to kill anyone, but it might show some benefit. And then just seeing how other people throughout the US, etc., have been getting great results for it. In particular, Dr. Verone in Houston, he's using this and got something like a 90%, 96% success rate in treating and discharging patients from his ICU. So going back to your sort of original question about big pharma, the problem with this therapy is it's all cheap drugs. Corticosteroids, heparin, low molecular weight heparin, ascorbic acid, vitamin C, and other vitamins and adjuncts as well. So there's no money to be made. The money to be made isn't in those expensive designer drugs, such as the one that's hitting the news now, remdesivir, which there's been 2 or 3 trials, one in China that really didn't show any benefit, and another, I think, in the US that showed a reduction in time to recovery, but not really any statistical benefit on mortality. Yet they're now promoting this and selling it for something nearly like $3,200 for a 5-day course of treatment for very little cost benefit. So I think the answer to the question is big pharma. They obviously, their bottom line is to make money. Us guys are, what we want to do is save lives, because if you look at the number of people that have died from this illness, it's horrendous, and anything that might help, is great. I just wanted to try and find something that, one, would keep people off ventilators and reduce the course and mortality of this illness. And I say the only thing that's really come out of big pharma is the remdesivir at the moment, and I say I don't think it's really of that much benefit, and certainly not at the amount of price they're asking people to pay for it in this condition.
You're absolutely right. As far as remdesivir goes, I mean, the Tamil Nadu expert panel has just introduced remdesivir as a new drug in their treatment protocol. So maybe Dr. Paranaman, there's a need to rethink that. I'm coming to you, Dr. Giridhar. I think this is such a fantastic initiative, at least as far as I'm concerned, because we're getting 3 fabulous specialists two from the US, one from the UK, and you know, two people from India. And we're all exchanging notes, we're exchanging ideas. And this is exactly what you're trying to do, aren't you? You're trying to get people to collaborate and at least publish basic reports based on hospital analysis. So could you tell us a little bit about what you're trying to do?
Okay, so basically, the challenge in India that I have actually observed ever since the pandemic had started was the data has been, pretty much, opaque. The kind of data that we really need for, clinicians, epidemiologists to really, dig in and try to make some really good inferences, understand what is good, what is bad, what can be taken. Has not been that open. I mean, from what I have seen in India, I mean, you can just see the total number of cases, deaths, recovered, and even as an epidemiologist, like if I have to look into any kind of analysis, I have to dig into some kind of global literature for some estimates. So the idea that actually came, to check into clinical parameters was that India is a very heterogeneous country, and each state has got a population that is equivalent to a European country, and hence the kind of protocols and the kind of treatment strategies that doctors they use, it actually changes. I mean, you just cross 100 miles, I'm sure that the clinician 100 miles away would think a little different. He might try to think, okay, why not do this? So the challenge that I really felt was, there are some places wherein, like specifically like where Dr. Parandaman is treating, Chennai and Tamil Nadu has been really doing good in terms of case fatality rates. It's somewhere around 1.5 to 2%. However, if you look into the entire national average and in high incidence states of India, it's somewhere around 6 to 7%. So yes, we really don't know whether it is the the methylprednisolones and the kind of protocols that's been following, but the evidence that that really needs to come up from hospital data becomes more crucial, because right now India is actually in a very steep peak, and since we're expecting to see more cases coming up, India is unlocking down, and people are moving, they're traveling, they're going by bus, by public transport and all those things. Yes, of course, people do wear masks, and the government has been promoting social distancing. However, yes, considering the fact that there are more patients whom you can expect to get admitted in days to come, I think a homogeneous, or rather a systematic review of all the existing literature, or rather a collab based analysis could actually help a lot. I'm not just taking Dr. Parandaman's hospital data. It could be global data. It could be data from other parts of the country as well. And that's the reason why me and my team, we have actually started a website by the name of covidtoday.in. And the main importance of that website is to initially to start with epidemiological indicators, but we are slowly planning to extend meta-analysis of different drugs, trying to put forums like these wherein you can just put some really hot discussions on what needs to be done, so that these kind of treatment protocols can actually reach to the the far ends of the country. And that's the main idea behind my purpose of getting into a collaboration. Yeah.
So collaboration is the way to go forward, and I'm going to invite everybody to jump in whenever you feel that you want to make a point. I'll probably start with Dr. Meduri. What is the problem in terms of communication? Why are, say, the premier institutions in India, the nodal bodies in India, why are they not communicating with American associations of doctors or whatever it is? There are so many bodies which can talk to each other, share information, drop little notes, reports, small reports, which we don't have to. Dr. Parandaman does not have to sit in Tamil Nadu and do it all by himself from scratch, and you don't have to sit and do it all by yourself from scratch. We can share information and save lives quicker. So why is this communication not taking place? And please feel free, anybody, to jump in.
Well, I'm going to go back a little bit to what you say about the drug companies. In the United States and in most of the industrialized world, the drug companies are the one that dictate the information that goes out, and they they're pretty much, they're very smart. They got outstanding the best public relation people are the one that can be bought with a lot of money, and they got plenty of money. So the public relation people, they give their messages, okay? They can be sometimes very subdued or get very clear, in which, oh, steroids don't work, or this doesn't work, whatever. Why? Because compete with them. I mean, if you look at TOSI, whatever, IL-6 inhibitor, we have studied on methylprednisolone that is outstanding inhibitor of IL-6 and everything else that is involved with the disease. It's not just IL-6, but the drug company are very good. So they are the one that set the message. And so we don't have an avenue. There is a lot of noise out there. It's very difficult for us to get a message out. Now, the society of the different infectious disease, critical care, so forth, are also influenced by the industry. And they're the one that people look at. People, today we are so busy, so overloaded information. People want to go straight to the recommendation by a society. So that's the one that they follow. What the WHO say, what the society say. It's very difficult to get independent thinkers out there that have an avenue to put their information out. Okay, so, you know, it's a tough time. It's very difficult. And, you know, and now there is an epidemic of websites opening with a lot of things regarding COVID-19. So it's very difficult to find a way to connect.
Dr. Corey, would you like to add something?
Yeah, Meth Plus, you know, is a website. So that's where people can look and send information and so forth. And maybe we should collaborate with you, you know, just so that people can look at both and et cetera, et cetera. Mm. And I want to say one other thing.
Yes.
Randomized studies, okay, are difficult to do and takes a lot of support to do that.
That was
And
my
now
next question. Yes.
Yeah, so now the medical journal wants to publish mainly randomized trials. I mean, we have a large prospective observational study, a cohort study, and we can get it published, you know, unless it's randomized, doesn't get published. So all the information out of the randomized studies. And so for steroids, we got the recovery, then we have all the other randomized studies supported by the industry. So they have all what it takes to get the information out there. We don't have it. Orphan drugs don't have a way to get information. So one question for India, is there any way that in India you can do a randomized study comparing dexamethasone to methylprednisolone, compare the recovery trial to methylprednisolone adjusted?
Dr. Giridhar can answer that.
Well, I'm not into the senior panel of doctors who are in AIIMS, but yes, there are some trials that have been registered in the present ethics committee, and they have registered in the CTRA, which is the National Trial Registration Board. But I haven't seen, you know, two different arms wherein you compare Dexa with methylprednisolone. It's like different, you know, studies altogether, wherein you have Dexa versus placebo. You have methylprednisolone versus placebo. You have the anti-HIV drugs versus placebo. That's all I'm saying. I even checked the clinicaltrials.gov for, you know, some extra records if available, and even the WHO repository of all the trials that have been registered. But I haven't seen a trial yet. Maybe it's still in ethics committee, or maybe they haven't registered it. I'm still not sure, but I can have a look at it. But from what you have said, I mean, from my side, I'm not very sure about it, whether we have a trial which compares Dexa with methylprednisolone. Yeah.
So India is such a large country, you know, maybe that's the best place to do it.
I totally get you. Yeah, it is. And it is definitely warranted because here, even methylprednisolone, the cost, I mean, in terms of, you know, private sectors, I mean, if you leave the public sector away, predominantly since the pandemic is getting spread into different societies and different segments of your population, private hospitals are ramped up, and more of their you know, treatment strategies have been you know, used. So the cost factor, what actually is being taken into consideration is that in terms of costs, Dexa is much cheaper as compared to methylprednisolone. That is one point which I have been listening from, you know, some colleagues of mine in private practice. The challenge of using Dexa or methylprednisolone is never an issue in a public sector because it's all free of cost. So, I mean, yes, in India, definitely such kind of data, even if not a randomized control trial, a good observation study or some kind of a cohort study with the follow-up of patients, and we can try to do some relative risk, adjusted relative risk. We could do some survival kind of analysis and try to see that. But I mean, the data, I mean, that's a big challenge that we are facing right now.
Is it even possible to do a randomized clinical trial at this time? I mean, why on earth would we give placebo to a bunch of patients who are infected by COVID? And Dr. Mitchell, please.
Yeah, well, I think ethically, you couldn't do a trial corticosteroids versus placebo now in light of especially the recovery trial data. You'd have to do a trial looking at, yes, the dexamethasone, well, whether it's at the dose given in the recovery trial at 6 milligrams per day versus higher dose of dexamethasone, or versus another corticosteroid, the one we propose as being better, as in methylprednisolone. But yeah, getting the data out of the recovery trial is showing it's got a decent mortality benefit. You can't compare steroids to placebo anymore. We've got to compare steroids to other steroids or combination therapies with the heparin. And the interesting thing would be if the ascorbic acid that is in the MAF therapy actually has a big dent in mortality on top of the corticosteroids.
Dr. Corey.
I just want to, probably be redundant to what Dr. Mitchell just said, but clearly with the very large recovery trial, ethically, you could not do a placebo versus a steroid. We actually knew that. I got to be careful how I say this, but our group knew that before the recovery trial. In fact, when we put out our protocol, there were a number of responses saying, nice ideas, but why don't you do a randomized controlled trial? What's interesting about randomized controlled trials, if you're the principal investigator, you have to have what's called clinical equipoise, meaning you have to truly believe that one treatment and another treatment, you don't know the difference. You think that they may be equivalent. You have to believe that in order to conduct a trial. If you know, for instance, someone like Dr. Meduri, who has 30 years of experience and who's one of the world experts in steroids, he knows for a fact that steroids are life-saving and are critical in treatment of critical illness. There's no way he could do a randomized controlled trial because he would be subjecting half of the patients to a placebo. Okay, so now the recovery's out. The world is clear. Steroids are life-saving, I believe. We were still waiting for the formal report. So you couldn't do placebo against steroids. But like Dr. Mitchell just said, and what Dr. Meduri just suggested, it would be interesting. I think there would be clinical equipoise, because what we're arguing is, I don't know that it's theoretical, because Dr. Meduri also is citing a lot of data showing that in prior pandemics, the methylprednisolone appears to be superior. But certainly there would be folks who would have clinical equipoise and could say, why don't we compare equivalent doses of one steroid versus another? That would be a good trial. Other great trials would be combinations. So full dose heparin with steroids versus prophylaxis doses. And those are some of the clinical questions that right now we really should focus in on. Is like, what is the best dose, duration, and drug that we should use? We know the general outlines of the therapy, which is anticoagulation is key, anti-inflammatory therapy or glucocorticoid therapy is key, and we should probably just polish exactly duration, dosage, and drugs. And I hope that's where the research is going to head.
Well, I hope so too, because I know Dr. Giridhar and Dr. Parandaman cannot say this, but India is a highly bureaucratic country, and government is a little painful, to get all these trials done. But yes, definitely.
We're not that different, Nadia.
Aren't you? Okay. Okay, that's good to hear that we're not alone. All right, so I'm a little this is pretty much my last question, and after that I'm going to ask you all for last thoughts. And this question to anybody, please feel free to jump in. We're not going to find a cure to COVID in the sense of a drug that kills the virus anytime soon, and a vaccine seems a few years away as well. So as doctors who are working in critical care, who are dealing with life and death situations every day, how important is managing the symptoms or the consequences of the disease a lot more important than actually bothering with a cure for COVID? What are your thoughts?
Can I say something? Because in your question, you mentioned that we're doctors in critical care, and here is the biggest challenge that we've had as critical care doctors is that we're really expert at caring for patients who come into an ICU who reach a certain level of critical illness. And we're very good at stabilizing and hopefully reversing that critical illness. This disease, what was really demoralizing for many intensivists or critical care doctors around the world is by the time they reach the ICU, and I've talked to doctors all over the country, and I'm from New York, I trained in New York, and all of my colleagues are in ICUs around New York, is the intensivists were demoralized. So many patients were so far advanced by the time they hit the ICU that they were essentially irrecoverable. And we saw so much death and such high mortalities. And what we kind of learned is that the challenge is we needed to get our non-ICU colleagues, the hospitalists, and I'm sure you have hospitalists in India as a different specialty, right? Is the doctors who specialize in taking care of non-critically ill but hospital level patients, is we needed them to be more aggressive. And that's what the recovery trial, that's the other breakthrough of recovery, is that it now gave guidance to doctors before the ICU to treat. And I think that's revolutionary, because what you're saying, like the vaccine, I don't want to be a total negativist, but I have to say, I know a little bit about the history of vaccine research in the prior pandemics. The vaccines actually were harmful and they were stopped. And so this idea that the vaccine is going to save us is not clear to me. It's really not clear that the vaccine is going to save it. Prevention is being problematic, especially in this country. I'm sure you guys are all reading the papers. The U.S. is a little, we're a little crazy here, okay? And so getting people to be compliant, and I don't know what India is like as far as adherence to mask wearing indoors, but we're having a lot of trouble getting
same problem.
So prevention is troubling, vaccine is troubling, and so really sound, effective treatment seems to be the best key. And what I love about the recovery trial is that it shows that earlier therapy, in the hospital, so that they don't come to the ICU. If you look at the history of this pandemic, what was so crazy as an intensivist is it completely collapsed critical care systems around the world. Like when it started, especially when you saw about Italy and Seattle, the ICUs were filling. They had to make and ramp up. There's hospital systems in New York that started at the pandemic with, let's say, for instance, Columbia, because I know their numbers. That's a big hospital system in New York City. They had 95 ICU beds within their system. In 2 weeks, they had to ramp up to 350 ICU beds. That's how many they had to make. So the ICUs were overwhelmed. And the reason why is because earlier therapy needed to happen. And so everybody's looking at the ICU doctors. And I got to tell you, in the ICU, I was trying to rescue patients, and I did rescue some, but many, I threw everything at them and I couldn't turn them around. And so for me, the revolution is that people recognize that steroids are critical, early therapy is critical, and I really think that'll change the trajectory of at least of the morbidity and mortality that we've seen.
In Memphis, we start steroids as soon as the patient comes to the emergency room and require oxygen. And let me tell you, our ICU admission, so we're gonna collect the data eventually, now we're too busy. But it works, and it's safe. This is the problem. Everybody said the steroids are unsafe. No, they're one of the most safe medications that we ever use.
And I also like to...
Oh, sorry, yeah. Dr. Giridhar, please go.
So I'll just like to add to what Dr. Corey had just said. I mean, treat the patients well when they reach the hospital. I think beyond that particular phenomena, in India, there is also one more issue which is actually creeping up. There is a lag between the patient, getting detected and reaching the hospital. So that actually, postpones the healthcare seeking behavior, because, it's not just in the urban areas. There are a lot of district hospitals and tertiary care, which are for some patients around 50 to 100 kilometers far off, and people don't really realize the kind of severity of the kind of disease. By the time they go, they get themselves tested, there is a lag of another 2-3 days for the results to come up, and by the time they really get themselves admitted, it's actually gone to the severity spectrum. I totally agree with your point. I mean, if you really get to nullify the disease progress from mild, moderate to severe, you would be able to really ensure that the mortality counts are less and the intensive care of the health system is not strangled much. So yeah, contact tracing has to be really uh, you know rigid and robust. At the same time, the mild and moderate cases have to be dealt with in a very timely manner. So can I just ask a question? I mean, in US, how much is the reporting lag in terms of detection of symptoms, and how quickly do they reach the health system?
Daddy, are you asking us in the United States?
Yeah, in the United States.
Yeah, it's interesting. As I was listening to you, this was my experience when I was in New York City. The dynamic was a little different. Early on in the pandemic, when everyone was like, could this be COVID? Could I have COVID? I think many people went to emergency rooms with very mild symptoms, even maybe a cough or a sore throat. After the inundation or after the surge where these hospitals were overwhelmed and everybody was sick and there was not enough resources and people became scared of the hospitals. And
Right.
I live in Wisconsin. I was at the University of Wisconsin. When I went to New York, it was after the surge, and it was at a time period where everybody had read all the newspaper articles and were suddenly now reluctant to go to the hospital. And so the patients I started seeing were extremely sick. I mean, they were basically decompensating at home, then showing up, and those
Yeah.
patients were actually hard to treat. And so I totally agree with you. It's almost a public health message, which is to
Yeah.
tell people and doctors two things. Number one is that as soon as you get the onset of, let's say, shortness of breath, I wouldn't say fever or sore throat or anything, but if you start to feel short of breath, you should be evaluated. That's number one. And number two, the testing, for me as a physician and as a clinician, I don't care about the test. If you present to me and I take a good history and a good physical, I mean, come on, the differentials right now for someone with a viral syndrome, it's COVID, 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 or maybe some mild benign virus. And so, I would argue the doctors should be treating empirically. And patients should really try to present early. The longer you wait, the much more risk you're going to put yourself at having medicines not work.
Right. Thanks, Dr. Kuri.
Dr. Mitchell, do you have anything to add?
Just to say that we've got to remember, the majority of people who get this disease, most of them have mild symptoms and often asymptomatic. We're looking at some figures, places, 40-45% people are asymptomatic and testing positive. So the thing we're trying to achieve here, I don't know whether we ever achieve a cure as such. We've not ever cured the common cold, it's to control the numbers of people hitting hospitals in a spike at once. So, hospital facilities, ICUs can cope. And also discussion of these therapies, can we give something to curtail the course of the illness if we get these people early with early hypoxia, early difficulty breathing? We don't need to be seeing people with a slight cough in hospital. It's the people that are starting to develop early respiratory symptoms that we can hit early with a therapy that works and prevent them escalating to needing, higher level ICU care and ventilators and overwhelming the system.
Dr. Parandaman, your thoughts? Anything you'd like to add?
What I feel is that there is no point in concentrating on asymptomatic and pre-symptomatic individuals, because 80% of the individuals are asymptomatic and pre-symptomatic. What is the most important is the 20%. The 20% they progress to severe illness, moderate, mild to moderate, and to severe, and 5% to critical. So it is not possible to concentrate on all individuals who is asymptomatic, and it's very tough to manage them. So you insist them on universal masking, hand hygiene, and reverse quarantine. those who are having the proneness of the disease or sickness, they should be having reverse quarantine. So you insist on reverse quarantine, insist on universal masking, insist on the hand hygiene and personal care, the hygienic care. The second thing is those who are symptomatic, that is 15% to 20% population, you invariably you should admit irrespective of the condition. You should have hospitalization for mild, moderate, severe, and critical. So every hospital should have four categories of blocks, and you should admit a patient. You should observe them for at least 7 to 8 days, 1 week minimum time, because by the time they develop breathlessness, it takes 7 days. Sometimes initially they may not have any symptoms. If you send them as a OP, outpatient, and ask them to come back after 7 days, they come back with severe breathlessness by the time the disease is severe. So instead of allowing them to come back after 7 days, you keep them for 7 days and observe if they are continue to be asymptomatic after the improvement. Probably you can discharge them and keep them in home quarantine. Otherwise, if it progresses, and you can shift from mild to moderate and treat you the protocol what you already started. If it progresses from mild to moderate, you make to severe, again you cut short at here. So you should admit all the patient for at least 1 week for observation and give the drugs to prevent developing from mild to moderate and moderate to severe to critical. Thereby, you can prevent at this level, because one prevention by the screening again is very difficult, as there is no antiviral effective drug, as there is no vaccine available. At least you pick up the patients who are symptomatic. Don't allow them to go home. Anybody is symptomatic, you should be hospitalized. At least how many days? At least 7 days. If they're so thoroughly all right, again, even after 7 days of they become all right, you advise them for home isolation for at least another 2 weeks, because any time of 3 weeks time they may progress late also. So if you follow that, probably you can tide over the crisis and you're able to manage. If you concentrate on screening, it's very difficult, especially in India. Now it's probably a community spread and very difficult to trace. And how many patients you screen, or how many patients you categorize them, put him on a community care center, that is a COVID care center. Very difficult for the government also to, this is very challenging. So instead, as a doctor, any patient who is symptomatic, admit and categorize, prevent all the, give all the drugs, use, institute the drugs, low mercury heparin, steroid as early as possible, because what the dose we use is 0.5 milligram per kg. It's not going to be immunosuppressive dose. It is only anti-inflammatory dose. If you go on a high dose, that is only immunosuppression. Let us not worry about the immunosuppression, because anti-inflammatory dose, you start early, and if the symptoms are mild, you give 0.5 milligram per kg. If symptoms are severe, probably you can 1 milligram per kg, not beyond that. That's how I feel probably we can overcome the situation now.
So that's absolutely wonderful. I mean, this has been a fantastic panel, to be honest, and I hope this leads to a collaboration in the future. And I hope Dr. Meduri and Dr. Corey and Dr. Mitchell, all of you take this forward and liaise with the Indian institutions and Dr. Parandaman's work as well. So so and maybe we can look at a more international collaboration that will benefit everybody and get a good treatment protocol out and save lives. So thank you very much for your time today. And yes, thank you. That's the new handshake, isn't it?
Thank you. So Indian follow. Okay.
That's the COVID
culture.
handshake. So thank you very much for your time. And I look forward to meeting you all again. Thank you so much.
Thank you.
you.
Thank you.